CE Conversations, a clinical podcast presented by Creative Educational Concepts designed to improve clinician performance and optimize patient outcomes. This session, Harnessing the Power of Immunotherapy in HCC and BTC, an expert exploration of the past, present, and future of checkpoint inhibition, is accredited for 1 hour of ACCME credit and supported by an independent educational grant from AstraZeneca. To earn CE credit for this activity, please visit the link in our show notes to complete the post-test and activity evaluation at the conclusion of the podcast. And with that, we'll turn it over to our expert faculty.
We're today going to go over several aspects of the immune environment in biliary tract and hepatocellular carcinoma, and then we're going to review both monotherapy, combination therapy in the advanced setting, and then we'll move towards combinatorial approaches with regional therapies in these diseases. And so you can see, for those in the room, we have paper syllabi as well as those online on Zoom. We can use this QR code to scan such that we could see the syllabus as well as answer any of the pre and post-test questions. Here, there are faculty disclosures. And we will especially thank CEC Oncology, who arranged this event, and this is supported by an independent educational grant from AstraZeneca. So thank you so much. So again, we will have some polling with this via Slido, which you can use your mobile phone to answer the questions both in person and online. If you do have questions for us, of course, you can type them into the chat and we will answer them at the end of the session. And then for those that are live, there are cards or simply come to a microphone during that portion of the session. So we do have a pre-test for sort of the CME credits. And so there are 3 questions. So the first question is, which of the following is true regarding the treatment of advanced and metastatic bile duct cancers? I won't read through all of the questions, but I will give you a few moments to go through and use Slido to answer the question. All right, so I don't necessarily, here, some answers are coming in. Give you some time. I don't think they're very hard questions, but let's try. Let's see what happens. If you're online, I'm waiting. Yeah. All right. So we'll talk about these at the end in the post-test. Let's move to the next question in the interest of time. So which of the following regimens has shown a statistically significant survival advantage over sorafenib or lenvatinib in treatment-naive HCC patients with intact liver function? And so we have the choices tremelimumab and durvalumab as an A, atezolizumab and bevacizumab, C and D, pembrolizumab and lenvatinib, and nivolumab. Has not. All right. All right, so we'll come and answer these at the end of the session. And then a case. So JJ is a 54-year-old male with metastatic HCC, no prior history of systemic therapy. One of the following systemic therapies are potential options given recent FDA approval and clinical trial data. So A is atezo-bev, B is tremi plus durva in the STRIDE regimen, C regorafenib, D cabozantinib, and E, A, and C. All right. And then, which of the following is true of the interventional radiologist's role in cancer patients receiving immunotherapy? They can A, obtain biopsies, B, interpret imaging findings, C, select optimal immunotherapy, D, perform ablation or embolization, B and D, or A, B, and D. All right. All right, we'll move to the next and then the post-test. So, I'll begin with just a brief overview of the immune function of the liver, evidence of immune dysfunction in HB cancers, and then the clinical data for using immune therapy, particularly as monotherapy in HCC and biliary tract cancers. So certainly there's compelling evidence to see the liver as an immune organ. And in this lovely schema from an excellent review, we can see that the liver is in a unique position in that it receives a dual blood supply. 10 to 15% of the blood supply comes from the hepatic artery, but about 80% comes from the portal vein from the gut. And in so doing, there are a variety of nutrients and lipids that we receive this way. However, there is also a variety of gut-derived pathogens, microbes, as well as endogenous antigens that are then filtered through the sinusoids of the liver. And because of this, the liver does have a unique place in maintaining tolerance while at the same time eradicating particular pathogens. And the liver immune microenvironment is extremely complicated and, of course, could be reviewed over several hours by basic scientists that study this space. But there are a variety of unique cell types, such as Kupffer cells, which is the intravascular liver-resident macrophage. These are critical for pathogen detection, capture, and clearance, and are also involved with antigen presentation and do have a role in maintaining an immune-tolerant liver. There's also liver sinusoid epithelial cells, which are barrier function, but also are involved with antigen presentation and tolerizing the liver, and a variety of other cell types necessary to activate both innate and adaptive immune responses. When thinking about the liver as an organ, much of these immune cells are spatially distributed in different portions of the liver, depending on where they are in the sinuses. And much more is still known about liver immunity rather than that of the biliary tree. And so this is important to note. In liver cancer, it's been fairly well established by a number of basic scientists as well as translational scientists that the cancer elicits a specific immune response, and up to about a third of these cancers from human cells, at least in translational studies, essentially have an illicit immune response through multi-omic type analysis. The majority, though, of these HCCs appear to be from a non-inflamed class and do not necessarily elicit an immune response. Preclinical data indicate that in syngeneic mouse models that anti-PD-1 and anti-CTLA-4 based therapy is an important target in this disease. Likewise, there is an immune response to biliary tract cancers. There have been several reports of larger data sets, again, looking at a multi-omic based approach, that there's a set cluster of patients and tumors that appear to elicit an immune response that is suppressed through immune checkpoint blockade. This may be less frequent. In addition, there are data that the microenvironment in biliary tract cancers is heavily immunosuppressive and may contain fibroblasts, making it more difficult to potentially elicit an immune response. So moving towards immune-based treatments in HCC, this has been a really, I think, an amazing time for anyone to be like a practitioner in this space, in that there are now several monotherapies for anti-PD-1 or PD-L1, as well as combination therapies with anti-CTLA-4 based therapy that have shown anti-tumor activity in this space. I think one of the first papers in this space, which was an IIT from Bruno Sangro, looked at the efficacy of anti-CTLA-4 blockade with tremelimumab in patients with HCC and chronic hepatitis C. I think some things are notable about this study in that it was a patient population that was heavily pretreated, a patient population with impaired liver function, about 40% with Child-Pugh criteria. Despite seeing a signal of a rise in LFTs, there was 17 to 18% of the patients that actually had an objective response, which I think is really one of the first good examples of potential anti-tumor activity with this class of drug. Since that time, there was also the evaluation of anti-PD-1 based therapy, nivolumab through the Checkmate 040 data, as well as pembrolizumab via the Keynote 224 data. What's, I think, notable about this is that in these single-arm studies, there was a really consistent response rate of about 15 to 20%, and the duration of response was quite durable, was long. In subset of these patients really had excellent disease control for an extended period of time, and this was very impressive to all of us in the clinical space. And so this warranted further testing on pivotal phase 3 studies. Pembrolizumab was assessed in the second line, first in Keynote 240, which was predominantly run in the Western population. Primary endpoint was OS and PFS. The study was negative for this, but there was a favorable trend towards overall survival, as well as a higher objective response rate with this when compared to best supportive care. A second study, Keynote 394, evaluated very similarly, though, in an Asian and Eastern population. This study did meet its endpoint of survival, and this is showing sort of a meta-analysis indicating that in the second line failing TKI, that there does appear to be some level of anti-tumor activity with anti-PD-1 monotherapy. But how does it fare in the frontline setting when compared to sorafenib? This brings us to Checkmate 459. This study was really a very anticipated study of comparing nivolumab to sorafenib with the primary objective of overall survival. Secondary and exploratory objectives noted here, a large study with 743 total participants. This study was unfortunately negative. There was no survival advantage to giving nivolumab that compared to sorafenib. And this study was not statistically significant, although there was a trend towards improvement and a tail of the survival curve that can be seen here. Likewise, when looking at PFS, there did seem to be a benefit to a subset of patients by looking at the tail of the curve, and again, this reproducible response rate. But other anti-PD-1 antibodies have been compared to sorafenib based on non-inferiority studies. Himalaya, which Dr. Kelly will discuss more, had a secondary objective of evaluating durvalumab versus sorafenib, and this was shown to be non-inferior. Likewise, recently reported at ESMO was the Rational 301 study, which showed tislelizumab was also non-inferior to sorafenib. And so clearly some evidence of anti-tumor activity, not necessarily enough to improve survival in the total patient population. And we'll have to talk about more about ways that that can be improved, and my colleagues will speak to that effect. Speaking of biliary tract cancers, stated some perceive this as a more immune suppressed microenvironment. With the exception of those biliary tract cancers that harbor microsatellite instability high or mismatch repair deficiency, which occurs in about 1 to 2% of this population. In an unselected patient population, several anti-PD-1 monotherapies have been evaluated, and response rates do appear to be lower than that seen with liver cancer. So to conclude, the liver clearly is a key immunologic function. It does help promote self-tolerance. The immune complement and function of the biliary tree and liver are different. Preclinical data indicate a clear role for targeting immune checkpoint inhibitors in this disease. The first attempts at monotherapy overall were not enough to move the bar away from single agent TKI, but had a really robust signal that a subset of patients are benefiting. And now there is really a movement in that space to combination therapy in the advanced stage, which Dr. Kelly will speak on next, as well as at earlier stages with regional therapy, which Dr. Salem will speak to. Biliary tract cancers are more difficult in terms of drugging immunologically, but we'll hear more about that in different ways in the future talks. So thank you for your time, and I will now pass over to Dr. Kelly. Thank you.
Thanks so much, Jim, and thanks to CEC for the opportunity to speak here today. So I'm Katie Kelly. I'm at UCSF in San Francisco. Here's the outline for my section. First, again, just summarize a little bit and highlight for the context of this talk what Jim has already presented so nicely, the rationale for immune checkpoint inhibition in both HCC and biliary tract cancers, and our current role for immune checkpoint inhibitor combination in both HCC and biliary tract, and of course, leading to future questions and directions. So as Jim mentioned, there's certainly rationale for immune checkpoint inhibition in HCC. We know it has a baseline immune suppressed microenvironment, which is very distinct from the non-tumor liver, preponderance of regulatory T cells and exhausted CD8 positive T cells. There are also a proportion, as Jim showed, 30-35% of HCCs with immune infiltrates that we might expect to be responsive to immune checkpoint inhibition, and also a subset of HCCs that are carcinogen-induced and may have a higher mutational burden, also features associated with immune checkpoint inhibitor response. So as Jim showed, we know from nivolumab that a subset of patients across etiologic and prior treatment subgroups, whether sorafenib naive or sorafenib progressors, Hep B, Hep C, and non-viral, will have durable responses to anti-PD-1 with nivolumab as monotherapy. This is the Checkmate 040 study, and you can see from the spider plots that in each of these groups, around 15% or so will have prolonged, deep, and durable responses. Now that prompted the phase 3 first-line study of the immune checkpoint inhibitor nivolumab as monotherapy versus our standard at the time of sorafenib, which Jim again showed. And I just want to highlight here again, as Jim said, this was a negative study. So, nivolumab did not significantly improve the primary endpoint of survival over sorafenib, but the key take-home message is this intriguing tail of the curve, which seems to increase over time and correlates roughly with the proportion of patients that had these deep and durable immune checkpoint inhibitor characteristic responses, which was about 15% in this study. And also really importantly, again, in the era of exploring immune checkpoint inhibition as monotherapy in a organ dysfunction population of HCC, we learned from Checkmate 459 in a large randomized phase 3 trial, multinational, that checkpoint inhibition was safe and was not associated with reactivation viral hepatitis and had no higher rates, in fact, arguably slightly lower rates of immune hepatitis than other solid tumor types. So highly reassuring and a very important landmark in the field for immune checkpoint inhibitor monotherapy, both efficacy and its safety. So with those features, efficacy in a subset, but not enough to beat sorafenib, and safety, that prompts the question of, well, how can we convert more than 15% to be responders through combinations? And so these are the 3 strategies that have been tested most to date. And of course, we're looking forward to many more approaches on the horizon, but simplistically, the combinations that have been studied are based on rationale in other tumor types as well as HCC, is immune checkpoint inhibitor with anti-VEGF monoclonal antibodies, specifically bevacizumab, with anti-angiogenic multi-kinase tyrosine kinase inhibitors, or with other immune checkpoint inhibitors targeting a different checkpoint. And so these are based on rationale we've heard a lot about in this meeting and in many other contexts. Obviously, targeting complementary immune checkpoint inhibitors offers the promise to elicit an immune response in a synergistic way or additive way. And then targeting anti-angiogenesis with immune checkpoint inhibition offers the promise of the anti-angiogenic effect on the immune microenvironment by inhibiting some of the VEGF-susceptible regulatory elements in an immune-suppressed microenvironment, as well as vascular normalization, which may promote immune responsiveness as well. And so the first such successful example, which has now become a standard in the field, was the IMbrave 150 trial, a phase 3 trial combining atezolizumab plus bevacizumab versus first-line sorafenib. And this is the schema shown here with 2-to-1 randomization, primary endpoints of both OS and progression-free survival. And these are the updated results presented at GI ASCO 2021, showing the median overall survival for the combination was 19.2 months versus 13.4 months for standard sorafenib. Prolonged PFS was also seen with the combination, and durable responses were seen in 30% of the combination arm. Again, about twice as much as we expect from an ICI as monotherapy, with 8% of patients having complete responses. And in combination, we saw acceptable safety in carefully screened patients. I should add that all patients in the study required an upper endoscopy due to the unique risk of upper GI bleeding in a portal hypertension cirrhotic population. And so that's an important consideration when factoring in the very selected population of this study. That said, though, this study has become the new benchmark for first-line therapy in HCC with these metrics, and it was approved as a regulatory standard of care in many worldwide. Now, when we look at the other way of combining immune checkpoint inhibition with anti-angiogenic agents, the option is immune checkpoint inhibitor plus tyrosine kinase inhibitors, and we've really seen mixed results across a variety of studies where we see activity, but not necessarily enough to achieve a positive study. So one such example is the COSMIC 312 study, which combined cabozantinib plus atezolizumab. And we can see here the dual primary endpoint of progression-free survival was significantly improved with PFS of 6.8 months for the combination versus 4.2 for sorafenib. But the dual primary endpoint of overall survival showed no difference between the two arms. And objective response rate was relatively low, around 12% for the combination. And thus the decision was made not to pursue regulatory approval for this regimen. Similarly, the LEAP-002 trial of lenvatinib plus pembrolizumab showed really encouraging efficacy in a phase 1b study with a high objective response rate of over 30%, leading to the phase 3 LEAP-002 trial shown here, comparing lenvatinib plus pembrolizumab versus lenvatinib alone as the control arm. And as presented at ESMO 2022, a couple of months back, unfortunately, the study did not meet its primary endpoints of improving OS or PFS, with lenvatinib as control arm performing extremely well, and the combination arm not showing superiority. Now, where the results are mixed is that we do have a positive study quite recently of immune checkpoint inhibitor plus a different tyrosine kinase inhibitor, rivoceranib, formerly known as ipatinib. So in this case, the immune checkpoint backbone is camrelizumab, and in this phase 3 study, the combination of camrelizumab plus rivoceranib did elicit a significant improvement in overall survival, hazard ratio 0.62 over sorafenib alone, and also showed improved objective response rate, 25.4%, and improved PFS. Now, of note with this particular combination, I'll talk in a minute about what are the differences in these TKIs, but we see with this combination that while the efficacy was superior to sorafenib, there was also a safety signal in that grade 3/4 treatment-related adverse events occurred in 80% of the combination arm, including 33% of patients with grade 3 or higher hepatotoxicity, which is a cautionary note in an organ dysfunction patient population at baseline. So these studies, the IMbrave 150 study of atezo plus bev, and then the multi-kinase inhibitor, immune checkpoint inhibitor combinations that I just showed you, raise a question of, what is the mechanism of activity here? Are we seeing synergy based on the cartoons I showed of how anti-angiogenics might promote immune response, or is it a sum of parts where some patients are getting responses from the anti-angiogenic and some are getting responses from the immune checkpoint? Is it just merely additive? And I don't think we know the answer to that, but I think highlighting here are these multi-kinase examples that show the target profiles are a little bit different, and their efficacy may relate in part to the activity on certain of these targets, in particular VEGFR2, which is the crux of VEGF signaling in the anti-angiogenic space of the immune microenvironment. So again, we don't know yet which is the best target and exactly how they're working together, but I wanted to highlight some recent data from a Nature Medicine paper from the results of the translational work from the IMbrave 150 phase 3 trial, plus the preceding phase 1b study, which looked at correlates of response to the atezo-bev regimen in both baseline archival samples, as well as a subset of around 14 patients that had paired pre and post-treatment samples. And this study showed an intriguing signal in the top panel curves on the right for kinase inhibitor domain receptor, which is also known as VEGF receptor 2. And as I mentioned earlier, this is really the key receptor in VEGF signaling that showed patients with high baseline VEGF receptor 2 were more likely to have a positive survival benefit from the atezo-bev regimen, and also had, so the baseline levels were associated with improved PFS and OS. And another intriguing finding, separate from the VEGF receptor 2 finding, was that responders also showed a decrease in Treg gene signature in their paired tumor samples. And so collectively suggesting that potentially the effects on VEGFR2, but also on regulatory T cells, may be indicators of mechanism. And we're still left with the question of, does multi-kinase inhibition beyond VEGF or VEGFR2 contribute additional benefit? And if so, which targets and which inhibitors? And that question remains unanswered. So shifting gears to the other type of combination, which has been most studied in this context, which are dual immune checkpoint inhibitor in combination. We have the Himalaya regimen shown here, which looks at the anti-PD-L1 durvalumab with or without tremelimumab versus the control arm of sorafenib. And this is a schema. Originally, it was a 4-arm trial with 2 different ways of combining durva plus tremi. The fourth dark blue arm was actually closed when, on a pre-planned analysis, it failed to differentiate from the top combination arm, which was called the STRIDE regimen. And that's sort of a unique way of giving tremelimumab with a CTLA-4 inhibitor with a single high dose on cycle 1, day 1, without subsequent dosing, in an effort to optimize the activation without and minimize toxicity based on phase 2 preceding study. And here we see the primary endpoints of OS showing significant improvement with the STRIDE single-dose tremelimumab plus continuous durvalumab arm. Durvalumab as a secondary endpoint, as Jim mentioned, showed non-inferiority to the control arm of sorafenib. And the objective response rate was 20% for the STRIDE combination versus 17% for durvalumab monotherapy alone versus 5% for sorafenib. And ultimately, this was a positive study, leading to FDA approval just last month. Now, we have other precedent for immune checkpoint inhibitors in combination. The nivolumab plus ipilimumab combination has already achieved accelerated regulatory approval in the second-line space after sorafenib, based on a cohort in the phase 1/2 CheckMate 040 second-line study, which looked at 3 different ipilimumab dosing in combination with nivolumab and showed objective responses in around 30% in all 3 combinations, and a survival benefit when compared to historical controls in this context, again, leading to regulatory approval. Now, of note, with the sequential dosing of ipilimumab in these cycles and the various doses ranging from 1 to 3 mg per kilogram, we do see a higher rate of immune-related toxicity with steroid requirements of 51% for the Nivo-1 Ipi-3 regimen, which was Arm A, which had the highest survival. And that's the one that has regulatory approval, but again, with the caveat for steroid requirement. There's an ongoing phase 3 in the frontline setting called CheckMate 9DW, looking at Nivo plus Ipi versus sorafenib or lenvatinib. So just to summarize, this is where we stand in 2022 for first-line HCC. We have the atezo-bev, IMbrave 150, durva plus single-dose tremelimumab, so-called STRIDE, and then the recent camrelizumab plus rivacetinib, formerly known as apatinib, phase 3 trials, all showing superior OS over sorafenib. As I showed from the Himalaya study, and as Jim showed, durvalumab and tislelizumab also have shown non-inferiority versus sorafenib. Now, in the second line, as Jim showed, the Keynote 240 study was negative, but 394 was positive, leading to regulatory approval of pembrolizumab. and Nivo plus IPI has an accelerated approval after sorafenib. Question remains, and Dr. Salem will be discussing whether there is a role and how to study this role in earlier stages. This is the Barcelona Clinic liver cancer algorithm is a widely used treatment algorithm worldwide, and we see here the implementation of these regimens in our clinical practice guidelines with atezo-bev and durva-tremi both listed as first-line options in the advanced HCC space. And our current treatment decisions are based on comorbidity profile, though we desperately need biomarkers to help choose between these. So quickly, in the last minute or two, looking at immune checkpoint inhibitors in biliary tract cancers, as Jim mentioned, unlike the 35% or so of HCCs which have immune infiltrates or features of immune responsiveness, biliary tract cancers are much colder, with probably less than 10% showing immune responsive features by immune profiling. Low rates of traditional biomarkers of immune checkpoint inhibitor response. Monotherapy response rates are 5 to 10%, so much lower than we see in HCC and other tumor types. In combination with chemotherapy, however, there is a signal for benefit, and here we see the TOPAZ-1 trial, which combined immune checkpoint inhibitor durvalumab with our standard first-line chemo of GemCis in a phase 3 trial. And just recently, this study showed that the combination of GemCis plus durvalumab improved all major efficacy endpoints: overall survival, PFS, and objective response rate over placebo plus GemCis. And the landmark, or the tails of the curve, plus the landmark proportions of patients with survival and PFS at 12 months and 18 months and 24 months show ongoing improvement, suggesting true synergy and immune response over time. And here are the PFS and objective response rate data for the TOPAZ-1 combination. Safety was very similar between the two arms, with a low rate of steroid requirement for immune-related adverse events, only 2.4% with grade 3 or 4 IRAEs. So this successful study led to the approval of durvalumab as part of our first-line armamentarium in advanced biliary tract cancer. And there are several ongoing trials ongoing. This is a summary of our NCCN guidelines, which have now incorporated GemCis plus durvalumab as a preferred category 1 level of evidence first-line therapy. So in terms of future directions and unanswered questions, there are many. We don't know yet what is the optimal combination partner or regimen for immune checkpoint inhibitors in HCC or biliary tract cancer for that matter. Right now, we make decisions in HCC based on clinical factors and toxicity profiles, but we need better clinical and biospecimen biomarker data to help guide these decisions of whether to use atezo-bev, durva-tremi, camrivaceranib, or other. And in biliary tract cancer, we don't yet know the optimal chemotherapy backbone or duration, or how to handle targeted therapy eligible patient subgroups like FGFR2 fusion or IDH1 mutation. Obviously, we're paying attention to this story in lung cancer with targeted therapies as well. We don't know yet which subpopulations are most likely to benefit. There is an intriguing signal for differential response in the setting of viral versus non-viral HCC that requires further study. And again, mechanism remains unclear for the different combination partners. And with that, I will close and say thank you for your attention.
Thank you. Thanks, Katie, and thanks for the opportunity to present on the role of interventional radiology in immuno-oncology. And just to sort of highlight the opportunity that I had last year, just to put a document together for context of the role of the IR with immunotherapy. And it really expands on what Katie was just talking about, which is taking a lot of information that the patient may have at the baseline, putting it together with whatever information there exists, either gut microbiome or other biopsy data and imaging data as a biomarker, for example, putting that together and coming up with prognostic or predictive factors of how patients will do, and also looking at how patients will respond depending on the types of treatment. So really very exciting to combine these types of therapies with the immuno-oncologies. And both panelists already talked about the guidelines. There is obviously a role of local regional therapy in those guidelines in the early intermediate setting for sure, as you can see here with ablation and the embolotherapy. So clearly somehow combining these things together is going to be a point of research in the future, and I think very exciting. But certainly as interventional radiologists, there's many places where we contribute to the management of the patient receiving immunotherapies and other types of treatment. that I'll share with you over the next few minutes. And the first one is the simple biopsy. Now biopsies can be challenging, they can be simple, but for example, needle gauge, location of lesion, et cetera, these are actually real challenges that can happen depending on the patient clinical context, their blood parameters, the location of the lesion, which one was biopsied first. So yes, we try to get the largest cores possible for information for you guys, but it can be challenging, and we work with you as best we can to make sure, because now biopsies are a dynamic process, multiple biopsies, the same lesion if possible, or a different one if it's progressing. So certainly something that we are looking at, and certainly a needle gauge is something that is a bit of a challenge. Of course, we know about intratumoral delivery, whether it be an oncolytic virus or a cytotoxic. This is stuff that we are already doing as part of clinical trials, where that's delivered, antigens are released and presented, and of course the immune system is now primed, and then through the bloodstream comes back all the way around to either the primary tumor or others, the beginnings of the abscopal effect. But already in practice now in certain cases, and in clinical trials for sure, this is where knowing exactly what we need to inject, when it was injected, and more sort of specific information on that strategy is certainly something I think we need to develop and work with oncology and hepatology to ensure that we're doing best in optimizing outcomes for patients. More specifically for patients receiving local regional therapy, ablation is a common one, of course. The idea being that you're ablating a lesion in the liver, for example, generating necrosis, and antigen release, as mentioned, with immune priming, and then going back again to the initial primary for anti-tumoral effect, necrosis, et cetera. And again, the possible mechanism of abscopal effect if that's something that you observe. The immunotherapies is also the other component where interventional radiology combines with the oncologists and hepatologists treating these patients. And just in brief, the embotherapies are the macroembolics and the microembolics. The macroembolics being that you starve the tumor with these particles. You may or may not inject some chemotherapeutics as part of that. And the microembolics tends to be the radioembolics, the yttrium-based radiotherapies. So multiple mechanisms that exist, all of which effectively increase CD4 and CD8. More specifically, there has been some work done on the effect of LRTs and HCCs, and that's been looked at. The immune infiltration, as Katie was mentioning, has been looked at in patients with various LRTs in surgical specimens. So it was noted, in fact, that the amount of infiltration wasn't that different if you looked at the chemoembolization and the no treatment resected specimens. But interestingly, those that received the yttrium-based therapies had increase in lymphocyte infiltration. And there seemed to be a dose dependence of that. The higher the dose, the more that occurred. And so that's an interesting observation and potentially something to consider as we look at future research trials. So the place where interventional radiology, interventional oncology helps, of course, is multifactorial and based on altering that microenvironment, releasing those antigens and helping augment the effect of the local regional therapy or the systemic therapy. There are ongoing clinical trials. Certainly, if you look above the chemoembolization combination clinical trials, there's a lot of exciting studies looking at combining atezo-bev versus TACE, for example, and BCLC-B, looking at time to treatment failure strategy, for example. So a lot of exciting places where that is being looked at in the embolotherapy space, and some novel places in the earlier setting with CERT, radioembolization, CERT-DERVA, for example, in patient population in earlier disease, looking at overall response rates. So a lot of places where there appears to be interest in combining these types of therapies. Now, the promise, of course, is to generate responses like this, a massive tumor with multifocal disease that gets treated, that you basically get a complete response. That's the 2-year follow-up scan. So that's basically what we're trying to chase and trying to identify biomarkers, whatever they may be, up front to basically predict this outcome. And one of the interesting things that we are doing research on, this is an yttrium-based treatment, and the advantage of yttrium-based radiotherapy is that you can see exactly where the radiotherapy was deposited. This is post-treatment confirmation, and there's radiotherapy in the tumor and nowhere else. So this is a distinct advantage over radiotherapies where rather than just modeled radiotherapy, this is a precision radiotherapy that can be confirmed it can be predicted with a diagnostic angiography and confirmed subsequently. Combination therapy, of course, is where all practice is leading in some form, not just combining various systemic agents, but also with local regional therapy. And it's important to recognize that the patient's HCC journey is quite complex and multifactorial and multidirectional. It is not left to right or right to left. It's probably more of a network map, as we have here in this patient, in our network map at Northwestern, looking at 300 patients. Some patients go on to local regional therapy, they get systemic therapy, back to resection, back to ablation. And if you look at the patient's course, that's basically what happens. It's never really left or right to left. They go back and forth. And the better these systemic agents are doing, the more sometimes you're going to see the need for a local regional therapy to augment the effect of the systemic therapy as opposed to just jumping into something else. And we can talk about that during the Q&A period or during the case example. In terms of interventional radiology expertise, obviously priming the immune system by ablation or cryoablation, whatever it may be. We obviously assist with image interpretation. That can be challenging. I'll mention that in a second. But obviously ablating or biopsying places in the body is where we contribute to the patient. And I think that's going to continue to increase as more and more therapies are developed. Imaging following IOs can be quite complex. Obviously, the most notorious example is that of the pseudo progression that can be seen where violating most of the rules that we know with RECIST, some lesions can increase in size. You break the rule and you continue treatment and you get a follow-up scan, and in many cases that was actually a response. And so the IM RECIST are clearly there to try to address these limitations. So there can be cases of hyperprogression, and I think we've all seen those kinds of cases. But certainly those that are pseudoprogression is really an area of significant interest from an imaging standpoint, because differentiating pseudoprogression from real progression is going to be a clear factor, because clearly some patients that are truly progressing, you are not altering their treatment, and that's something that we should identify certainly earlier. Response is something that is very important, and I thought I would show this graphic why response really matters, particularly if you have liver disease. And so this graphic here shows a few things, and just give me 1 second to explain. So if you have liver disease, liver cancer, HCC, and you believe in the concept that there is a lethal tumor load in the liver that will result in a demise, then that's the first concept. The second thing is these lines, the 3 lines, the blue, green, and purple, I guess, represent 3 types of treatments. One that gives you stable disease, one that gives you a minor response, one that gives you a major response. All 3 of them, if you see, have the same time to progression, or PFS. But it is the person that has the highest and deepest response that is furthest away from the lethal tumor load line. So somebody that's had a large tumor that shrank significantly is furthest away from this lethal tumor load in the liver line. And that's why looking at high response rate is clearly something that's become quite interesting, quite attractive for investigators. But that's sort of a graphic as to why things that have potentially the same PFS but a higher response rate is potentially a bigger benefit for the patient. This is an example of a patient with a significant liver disease, a multifocal disease that was treated with a local regional therapy with a retrorenal metastasis that at follow-up has a tremendous response of an LRT plus an immunotherapy, and the lesion behind the kidney vanished. So if you look on the right-hand side, the MET disappeared as well. So this is again the promise of what we are trying to do. I'm going to move forward in the interest of time because these slides were supposed to be hidden. But here what we have is just a few more comments on the ordering now of what we do when it comes to local regional therapies and systemic therapy. Theoretically, if you're looking at intermediate stage, when you have low burden, do you start with the LRT and then go on to systemic therapy? And if you have high burden, do you start with a reverse? I mean, I could argue either one in either scenario. But that's certainly something that we'll have to start investigating. Which one goes first? What are the adverse events that are tolerable and won't prevent someone from receiving the subsequent line of therapy? Certainly something that we are talking about. This has been investigated, and there certainly are some white papers that talk about the role of the interventional radiologist in immuno-oncology. And just to close off again, Tim Gretton and I in this manuscript also provide some context on some ideas on potential endpoints combining LRTs. and immunotherapies, and of course, various treatments that are extremely interesting. What combinations make sense? Is it on demand? Is it sequential, et cetera? So a lot of interesting things that are going on when you combine systemic and local regional. So I would just like to leave you that when you're thinking about combination therapies, that combining with LRTs is also something to consider. So to conclude, the immuno-oncologies, the immunotherapies, the IR therapies combine very well and certainly have been used by many of us in practice, and there has been no real safe signal in my opinion. So there are many cases on atezo-bev now, for example, that have stable disease and 95% of their tumor burden, that we now ablate one lesion or embolize one lesion and keep them on atezo-bev. That is something that is very attractive for all parties because it's maintained well for the patient. And again, because we have limited options, we can't just jump to the next treatment just because one small lesion is progressing. We will biopsy that lesion just to get some information on that on testing. Response rates that we have with local regional therapies alone range from 40 to 60, and when we combine them, they certainly exceed 60%, so that's something to think about. The management of HCC is extremely dynamic. I showed you a network map, and I think that is going to continue to become more complex. The BCLC algorithm, if you look at it from 20 years ago, was quite simplistic. You look at it now, it's even more complicated, so it's a very dynamic field and very interesting way as to how patients are going to navigate through HCC management. And ultimately, I think certainly the LRTs and the systemic therapies are going to continue to play a complementary role. Thank you for your attention.
So we have a few cases that we're going to walk through with this expert panel, maybe to drive some points home or touch on some things that we weren't necessarily able to do. So our first case is a 69-year-old woman that has this history of weight loss, chronic hepatitis B virus on tenofovir with a viral response, minimal surgical, social, or family history. And so she presents to her primary care doctor. This leads to imaging. Ultimately, laboratories indicate, intact liver function. Child's PUA platelet count is 200,000. AFP is quite elevated, 45,000. And imaging findings illustrate a solitary but massive lesion in the right lobe. By LIRADS, this was a LIRADS 5 lesion. And so I guess I would turn to my colleagues here to say, how would you manage this case moving forward? And if this patient presented to your disease management team, what would you consider?
I think it's key that she has Hep B and not Hep C or fatty liver or alcoholic liver disease, in that we know that some patients with prolonged viral control with their Hep B may be non-cirrhotic when they get cancer, and it looks like her liver looks pretty normal visually, and she has a pretty large left lobe. And so I think if it's truly a solitary lesion, and which I think the right of first refusal would be to send her to the surgeon to say, can you resect this with curative intent? But with the caveat, with an AFP that high, she has an extremely high risk. And if there are truly satellites or multiplicity, the risk of recurrence would be very high.
Sure. And do you agree?
I would agree with that. Clearly, with this kind of liver, what it looks like, surgical resection of the right lobe with satellites would be something to consider.
But in this particular case, the patient was reviewed at DMT. A surgical resection was ultimately recommended. Pathology demonstrated a T3B lesion, so it was poorly differentiated as solitary, but there was some vascular involvement. She completely recovered, and 4 weeks after surgery, her AFP improved but didn't completely normalize. Imaging showed no evidence of HCC. So again, to the panel, would there be any role to do anything else at this point?
I think you're getting at the question of what's the role for adjuvant therapy. And my stance right now is that we don't have enough data to justify using adjuvant therapy until we see any phase 3 results coming in. There are multiple ongoing phase 3 trials of checkpoint inhibitor monotherapy as adjuvant, as well as atezo-bev as adjuvant. And thus far, we don't have enough data to justify, in my mind, using it in this context. So I would caution, the patient that the AFP is hard to interpret immediately postoperative. It sometimes can be associated with regenerative process in the remnant lobe, but that said, she's still super high risk for recurrence, so I would monitor very closely.
This is kind of was the consensus here. Isn't a proven adjuvant therapy. TKIs alone have been looked at in this space and did not seem to move the bar forward. There are a number of investigational strategies based on some of the data that Dr. Kelly presented in combinatorial approaches as adjuvant or even as monotherapy. So we did recommend expectant observation. The patient was seen and had laboratories fairly frequently over the first year. During that time period, the AFP continued to slowly rise, and imaging showed the emergence of bilateral pulmonary nodules. So I guess in this setting, what would you ultimately recommend we do now? So this is now apparent metastatic recurrence to the lung within the first year out of adjuvant therapy. So we saw data, I guess, for durva-tremi as well as atezo-bev and non-inferiority of anti-PD-1 therapy. If this patient were in your clinic, what would you offer them?
So I think right now, this patient would be a candidate for, so assuming that she has multiple lung mets and, occasionally if there's just a single met, I might consider local therapy if there's been a test of time that there's, but that's a rare case. So assuming there's multiple bilobar lung mets and the AFP is going up and we know she's high risk, I'd consider either atezo-bev or durva-tremi. This patient doesn't have significant portal hypertension, at least preoperatively she didn't, and is hep B, so she would need an endoscopy. But then it would be, but she also has non-threatening, disease. It's not going to imminently hurt her. So she could also consider doing durva-tremi and seeing if she's one of the patients with prolonged response. So I think this patient would be a candidate for either of those, and I would discuss both options.
So a shared decision-making model in the context of this. Just in terms of, let's say there were a solitary lesion, just as we have you here as an interventional radiologist, is there any role for ablation in that setting?
I mean, I think so. So Katie alluded to the test of time. So with a reasonable test of time in one lesion, I think it's reasonable to think about some sort of ablative type therapy. And depending on the location, it might even be SBRT type therapy, depending on whether we can get to it. So test of time is going to be part of it, and then multiplicity and location is going to be another one. But absolutely, there are times when there's one lesion, it occurs 18 months later, we ablate that and we move on.
All right. So at the time, the only choices for this patient were sorafenib or a clinical trial. The patient enrolled in a trial of anti-PD-PD-L1 monotherapy and actually did extraordinarily well, had a complete response. All disease in the lung melted away, AFP normalized to lower than it was postoperatively. I think I'll break away from the case in one way, and I'll ask my panelists, we did talk a lot about biomarkers. So is there anything about this case that makes this patient more likely to respond? Do we know, or what are proposed biomarkers that we might look at?
Well, I think we have seen from both checkpoint inhibitor monotherapy as well as combination with bevacizumab thus far that patients with hepatitis B virus trend towards better overall survival compared to patients with non-hep B, and patients with non-viral HCC trend towards worse survival. That said, these data are extremely messy, and we don't yet know whether it's a post-PFS phenomenon of downstream therapies or comorbidity, so it's not as simple as saying simplistically that hep B patients do better and non-viral do worse. That said, this patient is hep B and does not have fatty liver disease or any of the factors we think might be particularly immunosuppressive or create a less likelihood of response. So she has some of the clinical features associated with response, but again, with the caveat, we really don't understand whether it's a bystander effect or not.
Got it. Yeah, I mean, from the perspective that I see this, many biomarkers have been proposed, genomic, like TMB, Wnt-beta-catenin. It does seem that a lot of the data, though, really depends on what is the immune environment at that time right before treatment. In the past, people seem to be loath to biopsy HCC. Do you foresee that changing to try to define these biomarkers?
From a research perspective, I would vote yes. I assume Dr. Slim might.
So we obviously want to move this forward. I do think that we do have to be a little bit cautious. Sometimes the enthusiasm for biopsy and the amount of tissue gets a little bit excessive. I'm sure sometimes people are looking for 7 cores, 8 cores, 9 cores. Those are a lot of cores. In a liver like this that's non-cirrhotic, sure, no problem. But there are cases with very diseased livers, cirrhotic platelet counts that are limited, et cetera, where you could have very bad adverse events from the biopsy itself. So certainly, communicating with hepatology and oncology as to what the goal here is certainly something that we need to. But I would caution that we need to find a happy medium as to how many cores to get, because we can get adverse events, real adverse events.
Just the additional comment that diagnostic certainty is critical, and that while we all accept radiographic diagnosis in HCC, that radiographic diagnosis is largely based on liver-limited early phase and intermediate phase disease, and not in advanced metastatic patients with infiltrative tumors and much more complicated imaging. And a national audit from the UK looking at radiographic diagnosis followed up with confirmatory biopsy showed about a 7 to 10% misdiagnosis rate, where patients were actually about 7 to 10% had either cholangio or mixed HCC cholangio. And now that we have a plethora of new therapies for cholangio, including targeted therapies, we definitely don't want to miss a chance to treat a patient who might have an alternate systemic therapy. So my personal stance, and I think our institutional stance, is advanced disease patients who are eligible for potentially multiple lines of systemic therapy should get biopsied unless contraindicated.
This is how I practice as well. So for this patient, she did really well for about 1.5 years, then developed some new epigastric pain, nausea, water breath. She started to lose weight, a physical exam showing pain in the tenderness in the right upper quadrant epigastric region. She had full laboratories at the time, all were unremarkable, looked at lipase, looked at AFP, everything normal. It was not doing well. What would you propose we do now?
A scan?
Yeah.
Oh.
No, here's a scan.
Okay,
we did get a scan.
Great.
So I don't know if you want to comment on the scan or if you see anything that's abnormal on the scan here.
I don't know that I see hypertrophy left low from the resection.
I was going to say, for those of you who don't see many HCC patients, you can see the nice remnant lobe hypertrophy, unique, beautiful characteristic of the liver after resection.
It's thickened, but I don't see anything else otherwise.
Yeah, so this is true. Initially, I think this scan was a possibility of progression of disease. The gastric wall was thickened, and there were some actual regional nodes that were enlarged. We did get an upper endoscopy, which showed sort of diffuse ulceration of the stomach and evidence of inflammation. Biopsy actually showed a brisk lymphocytic infiltrate into the tissue, and really the diagnosis that was made here was an immune-mediated gastritis. And this patient was actually treated counterintuitively with high-dose steroids and PPI, and with serial imaging improved. So just really a case to illustrate immune-related adverse events and the need to manage them here. This patient still is alive 7 years later, NED. So we're running close on time. So for this second case, very similar actually, and it comes to a question from the audience as well. In this case, it was an HCV-associated HCC. How do oncology and interventional radiologists come together in regard to treatment? This patient, all very similar. There were some concerns about surgery based on the size of the lesion and the lower platelet count. So can you, for us, Dr. Salam?
I mean, obviously, all of these cases are reviewed at our tumor board. We have oncology and hepatology that are present. We try to see if we can fit the patient into some type of curative therapy. Is this person maybe not resectable now? Can they become resectable? Can we embed a test of time by treating to see how it goes, and then potentially resecting? So we will try that first. Again, there's a nice plane there, but we will try some sort of local regional therapy in many cases like this if they're tolerant. Get a 2 or 3 month test of time, see if they can be converted to resection, see if the platelet counts can be managed, and otherwise, if not, then LRT plus or minus systemic therapy.
Yeah, so this case, the patient did have embolization. It responded nicely over 6 months. And in the interest of time, the patient was taken to the OR, disease was removed, but again, unfortunately had a recurrence of disease here, high-risk disease. In this case, was treated with atezo-bev with ongoing response. So I think because of time, I think we now need to thank our panelists and move to the post-test questions. So this is exactly the same questions that we asked before. We'd ask the audience on Zoom, if you can answer these questions, which of the following is true regarding the treatment of advanced metastatic bile duct cancers? I don't know. All right, I will move, well, I'll give it another second. Thank you to all of you on Zoom.
Gemcis plus durvalumab from the TOPAZ-1 trial was the recent advance in biliary tract cancer is now the standard of care for eligible patients without contraindications.
Great. So we'll move to the next one. Which of the following regimens was not shown a statistically significant survival advantage over sorafenib or lenvatinib in treatment-naive HCC patients with intact liver function? So it looks that that is the correct answer, C and D. So pembro and lenvatinib and nivolumab did not meet the superiority boundaries. All right, great. And then in this case presentation, very similar to the two that we've seen, in this case, de novo metastatic disease, what are the potential FDA-approved options in the frontline setting based on these recent clinicals? And that, I'm going to bias you, that's correct. So atezo-bev and the STRIDE durva-tremi. And then our last question, so which is true of the interventional radiologist's role in cancer patients receiving immunotherapy?
So this question just demonstrates that we'll help you with tissue biopsy and imaging findings and help with some local treatments, but we will stay in our lane and we will not select the
Going to select the immunotherapy for us?
Opinions are welcome.
We do welcome your opinion. They are experts.
Yes.
So, all right. So again, really thank you to the audience that are here. Thank you for CEC Concepts for this sponsored independently through AZ. Thank you very much to my colleagues. I always learn a lot from hearing you speak, and I hope the audience felt the same way. So thank you again, and enjoy the rest of the SITC meeting.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and, most importantly, for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.